Yeah, and I am presenting a study titled Depression Among Pregnant Teenagers, a study that was conducted in southwestern Uganda in primary healthcare facilities. However, this study um, was conducted to solve a problem of mental health problems that we have noticed among young pregnant teenagers, and we found literature says that depression is common among females, among women. However, among adolescents, depression is even higher among adolescent females. We also found that pregnancy increases the risk of depression, but also among pregnant teenagers, they are there are physiological changes of adolescents that are still ongoing, that on which pregnant or pregnancy-related changes compound and complicate their psychological well-being, which further worsens or increases the risk for depression. However, in our setting, we have not found a study that um, reported or explored depression among this vulnerable group. So we conducted this study, and our study was it's the aim of our study was twofold: was to report the prevalence of depression, but also to assess factors associated with depression among pregnant teenagers. So we conducted a cross-sectional study among 373 pregnant adolescents from lower health facilities, that's health center 3s and health center 4s, facilities that have a high number of pregnant teenagers in our setting. And we explored depression using the Edinburgh postnatal depression scale, which had been validated already for use among this population, whether to assess depression before or after their delivery. We also assessed for other key predictors of depression, and these included food insecurity, social support, resilience, alcohol use, and other key demographic factors. Now, for our first objective, we found that depression was high, over 39%, almost 40%, meaning that for every 10 adolescents, 4 of them are likely to have depression. And this was commonly reported in many studies, which found a very high prevalence of depression among this age group, for the reasons that I reported in the beginning. But also, we found that alcohol use and food insecurity increase the risk of depression in this age group. And alcohol use in our setting has been socially normalized as a coping mechanism to mental health problems, especially among young people. So alcohol use could be associated with depression in this case because it has been used as a coping mechanism. But also, some adolescents who use alcohol are likely to get unintended pregnancies, and therefore that actually even worsens their use of alcohol because of risk sexual behaviors. However, also food insecurity has been linked to depression, where those with food insecurity have a higher likelihood or higher odds of being depressed. And still, food insecurity in our setting where we have lower resources and adolescents suffer from food insecurity because of limited support. They cannot, afford nutritional diets during pregnancy. Their spouses are not supportive. That also worsens their psychological distress, in addition to the food insecurity, plus the social stressors, the stigma, and that could also push them into depression, but also alcohol use as a coping mechanism. We also found that family social support and resilience lowered the odds of depression among this group. So those are opportunities to help pregnant teenagers have better mental health outcomes through engaging their families and through building resilience among them. So this study pointed out very key factors that could be used to inform healthcare interventions, community interventions, but also modify our clinical practice through screening for depression, screening for alcohol use, but also engaging the community in identifying and supporting such vulnerable population. This is the abstract I'm submitting, and I hope this study has contributed to improvement of youth mental health. Thank you.
Thank you very much, Dr. Moses Mwanguzi. I think he's in attendance. Maybe you can stand and wave to the crowd so that they can see you. So this is evidence that we are not only local, but we are regional and international. Sorry, I'm talking a lot because I'm trying to buy time. So we will have our next presentation by Dr. Sylvia Kimotho. It will also be part of the registrar's competition. So she will also be, it will also be presented on the screens. I think I saw her around. Maybe she can also raise up and say hi. Or maybe she was anxious about seeing herself. Probably she was anxious. I hope they don't lose marks for that. They don't. So yeah, technical team is asking me to maybe ask you a few questions. And I think I will ask Dr. Sumeya to tell us what the highlights for the day have been so far. And to also introduce herself.
So while Dr. Sumeya has a minute to gather her thoughts and is on the way, I have to apologize for giving you fake news. In the earlier presentation, I started a rumor that DBS, deep brain stimulation, is available. It is not in Kenya yet, but we do have vagal nerve stimulation and we do have RTMS. So if you have any patients that need those kind of interventions, come and discuss it with me informally. I won't charge you a fee. So we're coming up to the cutting edge. I think we're the only city in the region that has those facilities. Dr. Moses was saying he's not aware of that in Uganda, and I don't hear of it in Tanzania. Then I also wanted to take this opportunity, while I'm buying time, to thank the organizing committee. Because last year we had a conference, I felt like I was working quite hard. This year, I've just been sitting around doing nothing. Everybody else on the committee has been working hard. So I want to thank, first of all, the timekeepers who have the most difficult job at keeping their seniors on track. Arguing with Professor Atwoli, telling the moderators to hurry up. Thank you very much for that. You will not have any points deducted. Then I want to thank the moderators in advance for Professor Mbayo. Okay, we've got a lot of doctors who should be professors. We'll have to have a special meeting about that later. Thank you to the moderators for sticking to time. Everything has run to time so far until we had a technical problem. And thank you all for your patience with the technical problems. Then I want to thank our technical team, especially Yemi and Pendo and Zawadi, who have been there keeping an eye on our professionals at the sound and video decks. I have a photograph of Pendo holding a microphone to the laptop speaker. We are not in the 1980s. So we're hoping that at next year's conference, we'll move into the 21st century. I want to thank Dr. Joseph for looking after us, keeping us to time. And I want to thank the panelists, some of whom have joined the panel at very short notice. I won't name names. I think I've forgotten to thank somebody. Charlene, have I forgotten to thank somebody? On our committee. That's all. Are we ready for our next presentation? Good. Thank you so much. Dr. Samay, we'll come back to you.
Good afternoon, esteemed colleagues and participants. It is a privilege to share insights from our study, Prevalence of Depression and its Association with Burden of Care among Caregivers of Oncology Patients at the Kenyatta National Hospital. This work was conducted by myself, Dr. Pius Kigama, and Dr. Teresia Mutavi of the University of Nairobi, and it explores the mental health realities of family caregivers supporting cancer patients in Kenya. Background: family caregivers are the unsung heroes of cancer care. They provide emotional, physical, and logistical support, often at great personal cost. Globally, caregiving is linked to high rates of psychological distress, with up to 60% reporting symptoms of depression. In Kenya, cancer care is increasingly shifting towards home-based support, yet limited research has examined the mental health of caregivers, particularly younger adults who balance caregiving with education, career, and family responsibilities. Understanding prevalence of depression and its relationship to caregiver burden is critical, not only for oncology, but also within the broader discourse on youth mental health and care of an aging population. Methods: we conducted a descriptive cross-sectional study at Kenyatta National Hospital Cancer Treatment Center. Using systematic random sampling, we recruited 259 caregivers. Depression was measured using the PHQ-9, where caregiver burden was assessed with a Zarit burden interview. This approach allowed us to quantify both emotional strain and practical challenges. Key findings: our results revealed striking intergenerational dynamics. The median age of caregivers was 39 years, with most being between 25 and 34 years. This underscores the significant role of younger adults in caregiving. The mean age of patients was 53 years, reflecting the aging population under care. Nearly 1/4 of caregivers were caring for a parent. Depression prevalence was high, 44% reported moderate symptoms. Caregiver burden was substantial, with 37.8% experiencing high burden. Importantly, burden of care emerged as the strongest predictor of depression. These findings highlight the dual pressures faced by caregivers. Younger adults often experience disruption to education and career trajectories, while older caregivers contend with cumulative stress and health challenges of their own. In conclusion, caregiving for cancer patients in Kenya imposes significant psychological strain across generations. Yet, within this strain lies resilience. Families continue to provide care despite limited resources. Our study underscores the urgent need for age-sensitive psychosocial interventions that recognize the distinct challenges of younger and older caregivers, routine mental health screening for caregivers in oncology settings, and policies that acknowledge caregiving as an intergenerational reality, ensuring support systems that protect both youth and aging populations. As we advance the frontiers of mental health, let us remember that caregivers are not only supporters of patients, they are patients in their own right, deserving of care, compassion, and recognition. Thank you.
Please, another round of applause for her. So I think as the judges continue doing their judgment and sentencing, we will move on to the next. So the next session is on youth mental health, and no other person who is more youth than Dr. Anne Boyo, who was my teacher and still is my teacher at the University of Nairobi, currently the head of department of the Department of Mental Health. Welcome as a moderator.
Good afternoon, everyone. I'm just trying to find out whether as young, people are old when they still stick with something warm when it is still hot. So I would want to introduce our first speaker, and we get happy when we introduce our students. So I want to introduce Dr. Nasrat Fahiri. She's a dual-trained medical doctor and a clinical psychologist with a blend of medical and psychological knowledge. Nasrat provides comprehensive insights into the interplay between physical and mental health. Nasrat is passionate about promoting holistic care with a focus on psychotrauma. Let's welcome Dr. Nasrat.
Well, thank you, Dr. Mbayo, and thank you, Chiromo Hospital Group, for giving me a chance to present my abstract. I'm from Tanzania, and I'm so happy to be here, and I'm going to present the results of my thesis, which I did in my master's last year. I've just graduated a master's in clinical psychology, so I'm happy to have my teacher here. Yeah, so kindly share my slides. Yes. So the title of my study is I was determining the prevalence and factors associated with post-traumatic stress disorder symptoms among youth living with HIV in Arusha City, Tanzania. So this study was conducted by me, Professor Annie Obondo, and Professor Manasi at the University of Nairobi. So starting with the introduction, globally, 40.8 million people are living with HIV, of which 8% are youth. And coming to Tanzania, about 1.8 million people are living with HIV, whereby 115,000 are youth. So youth living with HIV account for 6% of AIDS-related death. So young people living with HIV are at increased risk of developing post-traumatic stress disorder, and this can be explained by the fact that they're in the critical stage of development, which is accompanied with social and psychological challenges, which is also compounded by the burden of living with the chronic illness like HIV. So PTSD need to be addressed as it has, it negatively impact adherence to antiretroviral therapy, it affects the immune function and overall quality of life. Next slide. Yeah, so the conceptual framework of my study aimed generally at understanding the relationship between trauma exposure and development of PTSD symptoms. And I was interested in looking at different demographic, social, and clinical factors associated with PTSD symptoms. Next. Yes, so this was a cross-sectional study which was conducted between April and June in 2025, utilizing a quantitative approach, and it was done at 3 hospitals in Arusha, Tanzania, and then this include Mount Meru Regional Referral Hospital, St. Elizabeth Hospital, which is a district-level hospital, and Levorothy Health Center. These are one among the Tier 1 health facilities with adolescent clinics, HIV clinics. So the sample size was about 153 young people aged 10 to 24 years who are living with HIV, who provided assent and or consent to participate in the study. Next. Yes, so in the methodology, starting with the recruitment procedures, I was able to obtain a list of young people who were registered at the clinic, and randomly selected participants, made appointment, and then we conducted the interviews at the facility. We were able to use different instruments. The researcher designed questionnaire, which captured the demographic characteristics. We also screened for adverse childhood experiences by using the WHO ACE international questionnaire. We screened for HIV-related stigma, both internal and external stigma, but also we are able to screen for the level of perceived social support system. And lastly, we screened for PTSD symptoms by using the UCLA PTSD reaction index tool, which is a standardized tool for screening PTSD among youth. So going to the results, starting with the general characteristics, the mean age of my study population was 18.5 years, and majority of my participants were aged 20 to 24 years, and majority of them were female, about 54.9%, and also 52.9% were out of school, but also about 21.6% of youth reported that both of their parents were deceased. But also there were high level of, they reported perceived social support, about 55.6%, and there was low HIV-related stigma of about 79.4%. Going to the clinical characteristics, next slide. Yes, we were also able to check their viral load status, whereby about 92.1% of our participants had less than 50 viral copies, meaning that they have achieved viral suppression, but also majority, about 55.3%, were in HIV stage 1 and 2, and about 55.3% reported to have lived with the disease for more than 5 years, and 71% reported to have good medication adherence. So going further to see the results of our screening, whereby we screen for adverse childhood experiences, and this comes in 3 important domains: the abuse, neglect, and household dysfunction domain. And in our findings, we found that the household dysfunction domain were the most common, with 32% of youth reported to experience parental separation and divorce. But also in the abuse domain, about 13.7% of youth reported to experience emotional abuse, and 7.7% reported to experience emotional neglect. Next slide. So we went further to determine the severity of adverse childhood experiences, whereby according to literature, having experienced 4 or more adverse childhood experiences is associated with development of mental health disorders and other comorbidities. And in our study, about 10.4% of our participants reported to have experienced 4 or more adverse childhood experiences. Now going to the prevalence. In our study, the overall prevalence of PTSD was 13.1%. And as you know, having PTSD means you have 4 major cluster symptoms. And here I wanted to show that despite that some of the youth did not meet the criteria for PTSD diagnosis, but they still experienced significant PTSD symptoms which warrant attention. As you can see, about 61.4% of participants had reported to have negative mood and cognition symptoms, and 24.8% had avoidance symptoms, both of which are subclinical, but they also warrant attention. Now we went to determine the factors associated with PTSD in this population. We did both bivariate analysis, and we went further to do a multivariate analysis. And 4 factors remain significant to be associated with PTSD symptoms, and this include death of a parent, whereby death of a parent had 4.6 times higher odds of developing PTSD as compared to those who had both parents alive, but also having high HIV-related stigma at 4.29 times higher odds of developing PTSD as compared to those who had low HIV-related stigma, and also those who had 4 or more adverse childhood experiences had 8.77 times higher odds of developing PTSD as compared to those who had no adverse childhood experiences. But also, it was not that for every unit increase in time since HIV status disclosure, the risk of the odds of developing PTSD was 1.14. So in conclusion, this study found that the prevalence of PTSD among youth aged 10 to 24 years was 13.1%. Mood and cognitive disturbance symptoms were the most common PTSD symptom cluster reported in this population, and significant factors associated with PTSD included number of years since HIV status disclosure, loss of a parent, IAC score of 4 or more, and high HIV-related stigma. So what I recommend is, next, we need to implement routine PTSD screening and integrate trauma-informed intervention within HIV care. We have to provide targeted support for youth with adverse childhood experiences to enhance coping skills, resilience, and overall well-being. But also we have to strengthen stigma reduction initiative, addressing both internalized and external stigma, and ensure continued psychosocial support for young people living with HIV. I would like to acknowledge my funders, the University of Nairobi and the Kilimanjaro Christian Research Institute in Tanzania for making this research possible. Thank you for your attention.
Thank you very much, Dr. Nasrath. These are future professors. When the standing itself, the presentation tells us of a future professor. We're supposed also to have Dr. Wawa before we start interacting with Hashia, right? All right. Since she has not arrived, we are going to have a panel discussion with Dr. Moses. And it's written myself, for sure it's not me. All right, the panel and the panelists are there. So we'll listen and have the panel discussion. Dr. Neil. So let's start with the experiences of first, Dr. Neil. You can tell us more the experience and the group of putting the researchers and the different discussions that you come up with. Maybe you can tell us you've put a mixture of all the different studies, those who are young, those who are a bit older. What's your experience?
I think as we begin the panel discussion, we must call for questions and discussion from the audience, because we had hoped that to have Dr. Wawa's presentation. She's on the way. But she might be 5 minutes, she might be 35 minutes. So let's just invite the audience to send us questions about the 3 presentations that we've had, and to write those on notes and send them forward. But I just want to thank the speakers who've highlighted so many things to do with trauma. And I think we have a bit of time. I'm just wondering if you can tell us a little bit more about what your experience was of doing the study.
Well, thank you. Yes, well, thank you. So as you can see, I was dealing with young people aged 10 to 24 years who are now living in low socioeconomic disadvantages environments in an area where there is limited mental health support, in an area where they're facing difficult economic challenges, but now there's also a lot of economic pressure. And when I was talking to those children, I was able to witness the struggle, and that made me curious to understand more about what exactly they're experiencing. And this was exactly made me focus on PTSD. But now I understood that when I'm dealing with post-trauma, I cannot neglect the role of adverse childhood experiences, childhood trauma, the trauma you experience when you are less than 18 years. And now we are talking with young people living with HIV who have been raised most probably by parents who are having a chronic illness, but also most of them are orphans. So I thought it's important to look of what they are getting, what they are going through. And yes, I was able to witness a lot of household dysfunction, as you can see, the parental separation and divorce, the emotional neglect, and now they are the one with no stable caregiver, limited social support, so they become vulnerable to different abuse and neglect. Yeah, so that's what is happening there. And now we are thinking of how better we can help them cope with the experience now. Yeah.
So one of the things we don't talk about much is the personal experience of the researcher going into an environment where there's so much difficulty.
Mm-hmm.
And I just thought that's a question that all three of you might have some comments on. By the time we come to a conference and we present the data, it's cleaned up, it's nice, but sometimes the experience of gathering the data and meeting those people can be quite overwhelming.
Yeah. Okay. Thank you. My name is Dr. Kimotho. My research was not specifically for the youth, but it did touch on the youth because the youth were a lot of caregivers in my study. My study was on prevalence of depression and its association with burden of care among caregivers of oncology patients at the KNH Cancer Treatment Center. So while we were collecting data at KNH, it related very closely to me because I'm particularly close to someone who was a caregiver of our cancer patients. So we could actually relate with what the caregivers were going through. A lot of our caregivers were caring for a parent. Around 25% of our caregivers were caring for a parent. Most of them were young people between 25 and 34 years. So that ties into the current discussion about youth mental health. The young people had to stop their academic duties, career trajectories to take part in caring for their patients and relatives who had cancer. And also we saw a lot of older people who have health challenges of their own, stopping to deal with their issues to take care of their younger relatives who were undergoing cancer treatment.
Thank you so much. I'm Moses Mwanguzi from Uganda. I don't know whether there's any Ugandan here. I think it's only me. My study looked at depression among pregnant teenagers, and this population is it's vulnerable, and their challenges are really not understood by both the systems and the community, because there is apportion blame. You're 14, 15 years, what happened? So when we're interviewing, we explored depression, but some of I happened to be among the research assistants, but at the same time, the principal investigator. What I wanted to understand what exactly they go through. It was meant to be a mixed study in the beginning, but later on we meant it a quantitative study only. But they experience a lot of psychological distress, how they are stigmatized while they are on they go for antenatal care. Older mothers look at them in a different way. Some of them are pushed away from the bench. So the prevalence of about 40% reflected what was exactly going on. But other issues like food insecurity were difficult to discuss because, and so what are you going to do about it? So as researchers, it becomes a difficult conversation to have with someone when they're going to tell you all this, what they're going through. You're not going to do anything about it. The only thing we did is that we referred those who had depression to a mental health facility, but other factors like food insecurity, resilience, alcohol use were very difficult to discuss with this population. Thank you.
There's a question for Nasrat as we wait. To Nasrat, with political violence that happened in Kenya in 2024, 2025, Tanzania in 2025, and Uganda in 2026, targeting youth perpetrated by the older generation. What's your opinion about mental health input going forth, and what should we do to address that?
Well, thank you so much for the question. Yeah, and thank you for pointing down the reality. Yes, trauma happens, and in our setting, it's inevitable sometimes because we have a lot of issues, and we should not sit down and watch, but as mental health profession, we should now think of what we can do. So as a mental health professional, my opinion is when trauma happens, we will have to intervene before a person develop a mental health condition. We don't have to sit here and wait for a person to develop PTSD symptom or depressive symptoms, but we need to strengthen our system in a way that we'll be able to provide mental health support to those who are experiencing traumatic experiences. So this is very common, not only the political violence, but there's a lot of traumatic incidents which provide near-death experiences, but they are not being addressed because of the limited system organization. So my role is, I feel like we really need to handle or to rescue these people before they develop the mental health conditions. So we need to have psychological first aids. We need to have proper prevention mental health program, but also make people aware, because some people do not know if they need help. Yeah, we have a lot of people suffering, but they're not even aware of mental health symptoms. They're not even aware of the risk factors. So we have a lot of work to do, but this will start by us who understand the system, and it's us who need to motivate or implement the interventions. Thank you.
Thank you very much. To Dr. Moses, was the zero status of the teenage mothers in Uganda assessed?
Yes, it was assessed. But it wasn't among the factors that we found significant statistically, but clinically it could be significant. Significantly associated with depression. So it could be significant clinically, but statistically it wasn't, because we had a few mothers who are HIV positive.
Okay, thank you. There is to Nasrat, Dr. Nasrat. CCC stroke HIV clinics and programs have psychosocial components. Do these facilities, I think where you did the studies, have them, and how are they structured to accommodate mental health care for the youth? This, the person wanted to compare with the Kenyan program.
Well, thank you for the question. So yes, we call them CTC in Tanzania clinics. There's some social support provided, specifically every Saturday, but they are peer-to-peer support. So it's where the adolescents, they come together, they, like every weekend, those who are around, they come together, and those who are above 20 years, they come to talk with those who are below 20 years, just to provide emotional support and make sure they feel safe. So there's nothing like a well-structured mental health care. There's no even screening of mental health disorder in the CTC clinic, but now it is being integrated. It started, I think, last year. So there are some kind of social support, but they are not that supportive, and they're not even provided by a mental health professions. Only CTC nurses, they're trying to do what they can manage to help those cope, the youth and adolescents cope with living with HIV.
Now, much as I'm a teacher, I'm trying to read the handwriting. I'm told the handwritings of Dactaris are. So forgive me if I make some mistakes here and there. I think this is also, I don't know whether it was Nasrat or both presenters. What would you recommend in terms of interventions to teenagers who are exposed to sexual abuse and now have hyper and are sexually active? How do you deal with trauma after exposure, I think, to SGBV and affected with HIV? I think there's one term there I did not get. Do you deal with? I think you can, both of you.
I can start. I think sexual violence is common, and I think it's not only contact, because I think we tend to think it's only contact sexual abuse, but it's now common through harassment, through technology, in quite many ways. But I think I think it should start from sensitization, and this could go to parents from a young age to know how to protect a child, and also to discuss those difficult conversations of sex education with their children. But I also think it's a multi-stakeholder problem. It involves not only the parents, it involves the teenagers. We need to learn about their experiences. Some of them are exposed to first to content before they indulge into risk sexual behaviors. So to me, I think it's a very big problem that even requires new policies. But I think actionable interventions could be those targeting the adolescents themselves, sex education, which is which has a cultural context, but also providing those emergency services in case they are victims of sexual abuse, to have both medical and psychological first aid. That's what I would think.
Well, thank you. I also have the same opinion. Like it's need a holistic approach, and I also volunteer to work in one among the foundation. It is called Hope and Love Foundation. It is in Tanzania. It's an organization which harbor specifically adolescents with sexual abuse, and I can tell it involves a lot of approach when dealing with them, from spiritual, making them feel safe, and then now they have a home, food support, and then now the mental health support, and even the legal part play a part. But it's become challenging because most of them are being abused by their parents, their aunties, their uncles. So it's become challenging when you involve the legal issue, because someone is not ready to see you doing a legal action to his or her uncle. So it's so controversial, but my opinion is it is something which need to start from the community itself, to sensitize the community about how sexual violence can lead to a lot of disadvantages, but also parenting styles, because most of them who are victims are those who are neglected or you are in a social disadvantaged groups. So we really need to start from the families, the society, and then now ensuring the safety, the mental health support, and making sure they get appropriate care. Thank you.
While you're still holding the mic, you're being asked what was the commonest type of trauma that you found?
Okay. The most common traumatic experience was the parental separation in the adverse childhood experience. But remember, both of my population have had a trauma of the news of HIV diagnosis was reported as the traumatic itself, all of the participants. Yeah.
Okay. Still, what percentage of the population of the young people recognized that they are suffering from PTSD, and when you assessed, they actually had PTSD?
That's interesting, and that give a most important thing. What I noticed is these adolescents, they don't even realize, like they have a certain symptom, but they are not aware if this is a PTSD symptom. But when you try to ask them, because now I was doing a one-on-one conversation, I was able to frame question in a way that they could understand. So we experience trauma differently, and I think young people express the traumatic experience differently. So we really need to be targeted and focused when dealing with trauma. Even the tools we are using to screen for PTSD among youth should be culturally appropriate, so that we can be able to understand how they feel. They experience trauma differently, and they experience symptom differently. I cannot tell the percent of those who understood, but I was able to witness that most of them didn't even know if they actually have PTSD symptoms.
Are there some who had sought help in health centers and had actually maybe were better?
Like recognizing that they have a PTSD and
they
seek help?
Yes.
No.
Okay. This is to all the researchers. In your research, with all the participants coming, the participants coming from the institutions, has this interested? How does this interest with those outside the circle, assuming outside the institution? Because the study was in institutions.
I'm not sure whether I got in the question. So we are comparing those who were in the institution compared to those who were outside the institution.
So yeah, they were coming from institutions. Does this intersect with those outside the institution? I think.
Okay, so this is what I've understood. So I'm comparing those who. So comparing those who, for example, my study was looking at depression among pregnant teenagers. So those who had come for antenatal care visits compared to those who do not come for antenatal care. I don't know whether that's the question. I would think that yes, there should be a very big difference there, because the reasons why they do not come for antenatal care, for example, could be things like socioeconomic challenges that could contribute to them failing to go for the clinic visit, which may also contribute to food insecurity as one of our predictors, but also the social support which we found, which was protective. Those who do not go for antenatal care could have compromised social support. I would think that there could be a very big difference between the ones who come for care versus those who don't come for care. Yeah, I don't know whether that answers the question.
Okay. To both of you, you are being asked what bias what bias did you have walking into your research and how did you address it?
So one of the biases in my study would be social desirability bias, where participants are likely to report what they want me to know, or what they expect that I need I'm seeking from them. And for that, we try to use standardized tools where it's been found that when such tools are administered, you're likely to get a more objective assessment. So that's what we did for our study.
Okay. I think the reporting bias, so I was dealing with sensitive questions, asking people the traumatic incidents can be difficult to tell. So they may be either under-reporting or over-reporting, depending on the comfortability and the stigma itself. But I tried to make the environment as comfortable as possible, ensuring confidentiality and making sure they feel comfortable, so to minimize the bias. I also used standardized tools so that I can be able to capture exactly the experiences.
Okay. To Daktari, the question is, what was the percentage of the participants that were students? They were ongoing with their education in the study. Daktari?
I may not remember the exact percentage, but we had a smaller percentage that was in school. Most of them were out of school or dropped out. They had dropped out of school, either due to pregnancy or other factors.
Okay, as we try to wind up, and since I'm here, I have one question, but let me read a quick one from here. What are your comments on maternity, considering international conversations about deciding birth rates, where more women are encouraged to be mothers when young and have more children in their youthful ages? What can we as a society do to support young and teen mothers?
That's an interesting question, which I may not have an exact answer because these are factors I don't really. You cannot have interventions, for example, that are going to be. Well, interventions could be like psychoeducating or educating mothers about that and encouraging them according to the guidelines. But there are many other factors that may not allow mothers to adhere to the guidelines. Yeah, but I think it's difficult, but it can be done through our institutions like Ministry of Health. Yeah.
Okay, I have 2 minutes. And I will just be selfish and ask a question to Nasrat. And the youth, your study was among youth who are in schools, I think.
Yeah, somewhere out of school,
Somewhere
other way in school.
Yeah.
Mhm.
For those who are in school, how well versed were the teachers in relation to mental health as you're working with, you are looking into trauma? So how well are they trained? How well are they able to recognize the mental health needs of the student? And that will be the last one.
Okay, thank you. Yes, so these adolescents who are in school, I think it depends which school are you. And most of them who are in private schools, they are at least established support from a counselor. They get some education from a counselor and some educational programs during their they schedule some time for making sure they provide education on mental health. But now going to those who are in government schools, there's a lot of challenge. Even if I want to make sure there is continuity of care when I finish addressing a mental health challenge, to ensure that even they continue to get support at school. I get a challenge because now there's the system is not existing. There's no counselor, there's no anything. So we just tell a school teacher to make sure they get a close support. But yes, there is a challenge in schools. Most schools, there's no existing mental health support system, which affect the continuity of care and overall awareness of mental health disorders in schools. So yes, we need to do something. Yeah.
Thank you very much. Let's give a round of applause to the presenters. And I'm very sorry if your question was not. Okay. So thank you very much to the presenters, young researchers, and who are going to do much as you get older and more experience. Thank you very much. Thank you. So we now welcome Dr. Wawa. She's coming. I think the traffic had our prayers so that it could pause a bit so that she can reach here fast enough. So we shall welcome Dr. Sarah Wawa, who is a child and adolescent psychiatrist in Kenya based at the Aga Khan University, Nairobi. She recently completed her training at Red Cross War Memorial Hospital, University of Cape Town, and joined the fraternity to become the third subspecialist in this field in the country. She has a special interest in health promotion and systems development in low and middle income settings. Her work focuses on strengthening child and adolescent mental health services through clinical excellence, research, policy engagement, and capacity building. She's actively involved in training undergraduate and postgraduate medical students and mentoring emerging mental health professionals. She is passionate about building sustainable mental health systems, advancing locally driven research, and shaping regional leadership in child and adolescent psychiatry. She is a strong proponent of maintaining work-life balance, enjoys marathons, and completed an ultimate human race during her fellowship training, running 90 kilometers from Durban to Pietermaritzburg. Oh, my tongue is happy. So let's welcome Dr. Wawa, 90 kilometers. Wow. Karibu sana daktari. Karibu sana.
I'm going to remove my mask. I'm sorry. I was welcomed back with a flu and a lot of other things. Yes, I had forgotten that traffic. Google Maps in Nairobi is a suggestion. It's not actually right. Yeah, I have now remembered. Sure. Okay. Thank you, everyone. It's funny when she said fraternity, I remembered it's only ladies, so probably it's a sorority, but we're welcoming other males into the subspecialty. So I will start. You've already had my name. So good afternoon. So I know my colleagues, sorry I came late, so I don't know who's here, but I can see my senior colleagues here. I'm sure my other colleagues are here as well. There might be educators, policymakers, other health professionals, and hopefully there are some young people who are present here as well. And it's an honor to speak to you about a subject that is deeply personal and of profound national importance. That's the mental health of young people in Kenya. Kenya is a youthful nation. So the latest statistics say that nearly 3/4 of our population is under 35. But if we want to add the Gen X's and the millennials who also identify as youth, we'll probably go higher than 70%. Okay, so this having such a high youthful population is described as our demographic dividend, which is a powerful engine for economic growth, innovation, and social transformation. But this demographic dividend is not automatic. It requires quite a lot of investment on our part. And one of the investments we can do is on the mental health of young people in the country. Because the health of a nation's future workforce, leaders, entrepreneurs, teachers, and parents depends not only on physical health, but also on emotional resilience, psychological stability, and social support. So mental health is not separate from development. I don't know if you agree with me. Mental health is development. Across Kenya today, these young people are navigating a world that is both exciting, but it can be overwhelming for them as well. They face an enormous opportunity, but also pressures. These are pressures like academic performance and recently securing employment in a very uncertain economy, having pressures from social media and digital comparison. And I know we've spoken about digital mental health earlier on, and also pressure within families and communities. Alongside these pressures that they're experiencing, many young people carry trauma, bullying, family conflict, poverty, violence, exposure to substances, and identity struggles, especially during adolescence. Globally, research has consistently shown that about half of all mental health conditions will start at around age 14, and many more will emerge during later adolescence and young adulthood. And meaning that youth mental health is not just a pediatric issue, it is a lifelong trajectory issue. Therefore, if we intervene early, we can change life outcomes. However, if we ignore early signs, we will see consequences later in adulthood, which include unemployment, chronic illnesses, substance use and dependence, and cycles of distress that affect families and our communities. One of the greatest challenges in youth mental health is that the suffering is invisible. And I have seen quite a lot of this, where a young person who is depressed will still continue to attend school. A young person who is struggling with anxiety may still perform well academically. And a young person who is experiencing trauma may remain silent for years. Because stigma exists, especially in our setting, many young people do not feel safe to talk about these experiences and end up feeling like these mental health challenges are a personal failure. We do realize that young people grow within families, within schools, within communities, and these environments can either protect the mental health or place additional strain on it. Families play an essential role in youth mental health. A child who feels listened to, supported, and understood is more likely to develop resilience. Teachers are also a very powerful tool, and it's usually the teacher who is the first adult to notice that there's a change from how the youth was acting before. Despite this growing awareness that we've been having, there's still a lot of gaps that are remaining in youth mental health in the country. I will speak for one of them, that specialized child and adolescent mental health services are limited in many parts of the country. And the people who take care of the youth's mental health usually don't have adequate supervision. Schools often lack trained counselors. Primary care facilities don't always have the tools. needed to identify early mental health concerns. And also the families most of the times don't know where to seek for help from. But these gaps that we have also present an opportunity. So an opportunity for us to build systems that prioritize prevention, early intervention, and accessible care. Because when young people receive timely support, the impact can be quite transformative. A teenager who receives help for anxiety may remain engaged in school and end up pursuing higher education. A child who has attentional difficulties, who receives proper support, may thrive academically rather than being labeled disruptive. So early intervention has been shown over and over again to improve mental health, education outcomes, family relationships, and long-term economic productivity. Another important pillar of progress is research, which I am sure we've spoken about today. Many of the mental health programs globally will rely on evidence, and in our country, most of the times we are relying on evidence that's generated in other regions. Kenya must then invest in locally relevant research. We need to understand how these mental health challenges present among Kenyan adolescents, how social and cultural factors influence help seeking, and which interventions work best in our context. Research transforms good intentions into effective policies and sustainable programs. Young people themselves must also be partners in shaping solutions. Across Kenya, the youth are creating peer support networks, they're advocating against stigma, they're using digital platforms to share mental health information, which is quite commendable, because when young people are involved in designing programs, the solutions are more relevant and more effective. I'd like us to imagine a Kenya where every young person has access to mental health support, every school has trained counselors, every primary health facilities routinely screen for mental health concerns, and families feel comfortable to seek help without shame. I think that vision is achievable, but it will require a lot of commitment from policymakers, educators, healthcare systems, communities who might be here today, and also the rest of us can think about what we can do in our little way to improve mental health among the youth. If there are any young people listening, your feelings matter. Seeking help is not weakness, it is courage. And for the rest of us, let us continue to strengthen mental health services for children and adolescents. Let us support schools to create safe environments. Let us invest in research and workforce training. And let us listen to young people and involve them in our solutions. Because when young minds are supported, communities will thrive. And when young people feel hopeful, nations will prosper. And when we invest in youth mental health today, we're building a stronger Kenya for generations to come. Thank you.
Thank you very much, Daktari. And I think as you came and being late, you perfected you had more ideas coming up. And if we gave you more time, you'd have told that much more. So, yes.
So, hi everyone. This is such a great opportunity for us to convene. And my name is Joanna Port. I'm with Africans for Mental Health. And what we are seeing in the United States, for example, I know you're talking about what's going on here, is training young people on the teen mental health first aid, so that then they can help in alleviating those pressure points of maybe their colleagues in school having challenges. In your research or in your work, are you seeing any affinity to having that kind of skill building in the community? And for example, in schools, I just spoke with someone who's saying that there's some situations happening at Kenya High School and State House High School, I think, and the young people are, experiencing an increase of suicide ideation. So, is there as you think of policy, thinking of what you can do in terms of skill building, and having something like a teen mental health first aid to help these young people with their mental health?
Thank you for that. So maybe I should give a disclaimer. I'm so fresh back in Kenya, so I might not know what is happening much. But interestingly, my research for the fellowship was on child and adolescent mental health services in the country. So I have done quite a lot of choosing, and one of the pillars is the mental health, having what is it called, partnerships with other facilities. So things like schools. Okay, so there's lots of youth-led mental health initiatives in the country, lots and lots of them, which is great. The problem is that there's no coordination. Yeah, and that's one of the recommendations from the research that I did, was that we need to have like a nationally coordinated youth service, especially when it comes to advocacy and creating awareness, which currently is not there. But I know it's something that they're working on. Yeah. It would be nice if there were none.
There's a question here. The growing influence of social media and digital.
Okay. With the growing influence of social media and digital environment, how do you see these factors shape youth mental health, and how can clinicians incorporate this in their assessment? Okay. So I know the older generation, we usually don't like social media and digital environment. Unfortunately, it's here to stay. It's here with us, and the current adolescents and Gen Zs and Gen Alphas, they're all digital natives. So there's nothing much we can do about that. We just need to learn how to incorporate this. Okay, so I'll just tell you, interestingly, one of my trainers asked me if I was on TikTok, and I said, TikTok, me? Why would I be on that? And she said that that's where all the adolescents are, that's where all the kids are. So how else are you going to talk to them? So that's a very nice place to start, if you're able to go in there and provide proper education, because we know most of the people who are there just giving out whatever information they've Googled, and they're not the professionals. So us as the professionals need to take up that space to start with that. And then, so that can actually help in creating awareness. And then how can clinicians incorporate this in their assessment? So I know lots of us are already doing online sessions. It has its good portions and its bad parts as well. You know, we like having the person in the room, being able to look at the gestures and facial expressions, because that helps us during our evaluation as well. But it's good because it might actually increase the number of people who can come see you, because all the 3 child and adolescent psychiatrists right now are in Nairobi. I can see the look of disappointment in her face. But that's the truth. So, but even for supervision, some of the things we're thinking of, like for the rest of the clinicians, how can we help them have the skills that we have and they don't have? And it might end up having to be an online platform, because we can't be everywhere at the same time. Okay.
Yeah, Sarah, just I would like you to say something about the capacity development that we are working on at ECOU in partnership with the Child Mind Institute and Stellenbosch. Just say something about that.
How much do you want me to say?
Say a lot.
Okay. So currently Aga Khan University has partnered with Stavros, SNF, Stavros, yeah, and the Child Mind Institute, and the goal of this partnership is to capacity build child and adolescent, not just psychiatry but mental health. So then what it's looking at is to pick professionals, so just not only doctors, psychiatrists, psychologists, occupational therapists, psychiatric nurses, and to train them. And because we still haven't put in place our what is it called? Like we haven't put our own training institutions, so we have to learn from other people. So this has been done in the past before, and it's been done with Mozambique and Portugal. So then we're doing a partnership with South Africa because a lot of us have been training there. And so the first cohort is going to be 3 people, and then probably we'll do 2 or 3 other cohorts, but with a plan of starting our own training locally so that we have sustainable training.
I'll ask you a very hard question. It borders on ethics, medicine, and politics. So it's a really hard one, but you've just come back and you're very clever. So don't worry about it. Before you came, while you're stuck in traffic, there's a question that I really was dying to ask, but then somebody else asked it.
Okay.
And it's about the Gen Z movements that we saw in June 2024 in Kenya. We saw some youthful activities in Tanzania and then in Uganda, Nigeria and other places. We know that some of the drivers of youth mental ill health are all the things that we've been told about, adverse childhood experiences and all those other things. But we also know that poor health in community, mental health, is driven by bad policies, the bad political leadership, inappropriate allocation of national resources, governance, all those things that I was told by my seniors, some of who are now dead of old age, that really doctors have no business in politics. And our business is with a stethoscope, looking through microscopes at stool of people and treating anemia and other things, and so on. Now, you are a freshly minted child and adolescent psychiatrist. When a 16-year-old boy or girl asks you, they might call you auntie or doctor, what must we do to these old idiots who are mismanaging the resources of our country to ensure that my future promised to me at independence is certain? What are you going to tell to the 16, 17-year-old about getting involved in societal? And if there is, what is the scientific basis for the answer you're about to give us?
So thank you, Dr. Njenka. Sorry, I got it. Okay, so before I answer anything, I'd just like to just give a disclaimer. Please don't report me. I don't want to be abducted or anything like that, because I've heard that has been happening. But what I would tell this, sometimes I wonder what I would tell them, because I myself sometimes feel a bit helpless about what's going on. But we do know that poor policies would lead to poor mental health. In fact, I think it was when I was doing the research, there's no allocation to child and adolescent mental health on its own. And the allocation to mental health is very small. I've seen Dr. Mercy there. I think it's less than 1% of the budget. It's 0.01%. Yeah, that's like really minimal, which means then we can't build all the things that we're talking about, those beautiful things that we are talking about. So how would this youth then get involved? I think the first thing I tell them is like, they just need to what is it called? Educate themselves about what is happening in the country, the kinds of things that are going on. And then they're still 16, so they can't vote, but they can start thinking about it. And I know sometimes I feel like my vote doesn't count. Please don't put that out there again. I really don't want to be abducted. But so I think that those are the kinds of things we talk about, like that they can change their what is going on, the bad policies and all that, by taking part in the voting process and thinking about what leaders would work for them, as opposed to us thinking of who's from my area and things like that, which is something that is very Kenyan that occurs. So education and voting. Thank you. I should have called on. That's the good thing about having a senior around here, is that you can actually push it to him. Thanks, Professor.
Thanks. I do not have the answer to Dr. Njenga's question because it's a difficult question.
I know.
and you've made a valiant attempt at answering it. But I think in times of crisis, one of the things that we advise people who are facing a mass crisis such as we are facing is to do something. Doing something helps to deal with your own stress during that crisis. And so I would tell young people to be involved, to educate themselves, as you've said, but also to speak out about the injustices they see around them, and to remind us that the future belongs to them, not to us, so that when we're doing stupid things, we should know that we are impacting their future, and that they make us aware that they are aware, and probably hold us to a high standard. I think the young people can do that. When they do that in sufficient numbers, then the power of operation is often dampened. It's difficult when you're few and alone and so on, but then when more and more young people speak out and act, governments tend to listen. The evidence of this is in 2024, June, in Kenya, where the young people looked at the budget and they rejected it. And then they forced the president to reject it. So for the first time in the entire history of the Republic of Kenya, there was no budget in June 2024. We operated on the budget from 2023 because the young people said we will not have it. So action helps. Despite the losses, despite the difficulties that they went through, what they wanted done was done. So I think that is the only thing I would add. Thank you.
As a current custodian of the so-called bad policies, which were made by the likes. Let me just add on to helping Dr. Wawa respond to that, is that when the young people ask you, most of the times we look at, when it comes to mental health, we look at the curative aspects, but we forget the big role that's played by promotion of wellness and prevention of illness. And I believe that the youth have such a strong power to influence mental health promotion and prevention of mental ill health. So if you can tell them that they may not be able to be powerful enough, maybe to vote, old enough to vote, old enough to influence policy, but they can actually impact at their personal spaces by being the ones who are speaking against bullying, against violence. And in the same digital space that we're speaking about, it is also a very big determinant of mental health, either mental ill health or good mental health. So if they are responsible, so you educate them on how they can promote wellness and prevent illness, even as we look into the policymakers to look for coins elsewhere. The budget for mental health in Kenya is 0.01% of the health budget, not of the entire budget. So do the math. Yeah. So I have empty coffers. I am a beggar most of the time, and I'm thankful because there are many people who are there to support, but that is what I'll tell them. Thank you.
Big clap to our presenter. One of the things we can do better than that. One of the things of being a teacher is that we know how to keep time. I was checking that, like 5 minutes, 2 minutes, and I just said, so thank you very much, Dr. Wawa. I'm hoping the parents who are there, I'm just closing, take advantage, are not the parents who may be the older parents like us, who when we're in school, they didn't understand the mental health. I hope they are doing a better job now and taking care of their children. Thank you very much. My time is up. Well, that one I can't say because we beaten, we were beaten. Now I don't know, but I don't think we complained even when we were beaten. Thank you very much, Dr. Nim.
Thank you very much, Mwalimu. Thank you very much, Dr. Wawa. I think we saved the best for last. So we're going home full. So we are coming almost towards the end, and it's now prize giving time. Remember, we discussed that there was a competition, and I think I will call the Chief Justice, Dr. Stacy Njani, to lead us in this session.
Hello, everyone. So I'm sure you enjoyed the videos that we watched. Can you hear me now? Okay. I'm sure we all enjoyed the videos thoroughly. They were very well done. So I'd like to start by congratulating everyone who submitted the video and took time to walk us through their presentation. It's really quite nerve-wracking to do the work in private and then suddenly all of these eyes of your seniors are just looking at you. So congratulations, that was a really good effort. So just to talk about everyone, I think each and every one of them did present a very relevant topic, and they were all very topics of very great public concern, and they were clearly presented. So that was a positive that each and every one of them had. The only key area of improvement I would suggest is, being the digital age, we could have had a bit more engaging videos and then have your voices as a voiceover. I think that would have been that would have been a really next level. So next year, the guys who present, I think that's something that they can try and achieve. And so with that, I will go ahead and announce I'll start with the silver medalist. No, sorry, I'll start with the gold medalist. And this presenter had a good flow of presentation from the problem to the policy. The video was engaging. It was edited in sections that were titled, which allowed us to follow the presentation with ease. And the quality of the video was pretty high quality, I think we'd all agree. And there's a nice little prop at the back that just engaged us visually. I think that was also good. So the medalist, the gold medalist, is Dr. Mekonnen from Ethiopia, who presented on problematic social media use. He's not present, so I'm not sure who you'll take it. So Dr. Karanja will help me in issuing the awards. So this is for Dr. Mekonnen. So you can find him on social media and tell him congratulations. Next, so all our other three are silver medalists. I was told you can come first, but not last. So we have a gold medalist, and then we have 3 silver medalists. So next, I will be awarding Sylvia Kimotho, Dr. Sylvia Kimotho, who had a presentation on, I think, a population we often forget, the caregivers, and they go through a lot, and she did a really good job in highlighting that. And I think each and every one of us now in our offices, after you talk to the patient, talk to the caregiver. So. Next, we have Dr. Diana Mboro. Is she in the room? Yes. So Dr. Diana also had a very interesting presentation, reminding us about adverse childhood effects and their long-term effects. So yeah, congratulations. And finally, Dr. Moses Mwanguzi from Uganda. Again, another population that we often forget, our teenagers. Congratulations. They won good things. I regretted dearly not submitting a video. So what they have won is very good. So thank you so much for the audience and my fellow judges. Thank you.
Good afternoon, everyone. My name is Dr. Angeline Tenge. I'm the IAPTA, that is Eastern Africa Young Psychiatrists and Trainee Association Secretary General. I'm here on behalf of the president. He was supposed to be here to give the awards, but he arrived in Kenya but got some problems at the airport. So unfortunately, he's from Tanzania. So I'm here on behalf of him. Just to remind us that IAPTA was established in 2007, and it's a professional network for young psychiatrists and trainees, and we try to bring ourselves together. So right now we are in Kenya, Rwanda, Tanzania, Uganda actively, and we are getting membership from Ethiopia. Right now you see somebody from Ethiopia has actually won. And our main aim is to promote mental health through training, mentorship, and research among these member organizations. So today, on behalf of IAPTA, I'd want to thank Dr. Njenga and the Chiromo Group for giving us this platform. This is the first time we've had IAPTA members actually competing with their presentations, and this platform is it's making us visible, and it's giving the early career psychiatrists opportunities to be seen. I'd also want to say that as part of our mission, as part of the objectives, is to bridge training gaps, foster continuous professional development, and enhance mental health services in East Africa. But then looking at IAPTA, it's within Eastern Africa, but then we're starting, because we're on their social media platforms, we're starting to expand our visibility. So I'd request all of us who are here, please follow us on LinkedIn, follow us on X, follow us on Facebook, on TikTok, and engage with us. And then another thing is we've started monthly CMEs, that is continuous medical education. Last month we had Uganda present as CME, and we had quite an amount of support. We had 58 attendees. This month, on the 3rd February of the month, our CMEs are on every 3rd February of the month, every 3rd Friday, sorry. Think I'm a bit anxious. Every 3rd Friday of the month, we'll have Kenya present, and for our senior psychiatrists, we'll be reaching out for support so that you can help facilitate the sessions, and then we'll get a trainee or a young or psychiatrist to present a case or a topic. So please, for all of us who are here, let's support what we are doing. And for all the IAPTA members, kindly let's support our association. This is the place whereby when we leverage the opportunities that we have, it enables us to actually grow. Thank you.
Our MC is busy, so allow me to introduce Dr. Karanja, another one in the long list of doctors who are awaiting their professorships. She's well known to all of us. Allow me to hand over to you.
Thank you, Dr. Horn. I'm a bit intimidated by podiums because half the time people can't see me. And that's not really my fault. You have to blame my parents for that and my genetics, but I hope you can see me. I did try to put on high heels. Yeah, the beauty of speaking last and you're told to do the closing remarks is that there are no questions that come with it. So put away those notebooks. You're not going to ask me questions. But before I speak, let me just redeem myself a little bit and redeem you, policymaker, by saying that not all policies go to gather dust in our shelves at the Ministry of Health and in our government offices. Dr. Frank Jenga here led a team of very able Kenyans, some of whom who are sitting in this room. And they did some great work about 6 years ago around mental health. That was a task force on mental health. And last year, during our National Mental Health Conference, we did an analysis of how much of the recommendations that they passed have actually been fulfilled. Do you want to tell them or do I tell them? I know Priscilla is in the house, and that is, Priscilla, out of the 15 recommendations, how many of those have been achieved? Yes. So you see, you should give yourself some credit. You did good work and it bore fruit. So, and another thing I wanted to mention, I don't know whether Dr. Ongecha is still in the house. Yes, redeeming ourselves again, that we do work, is that, what did you say about the PET scan?
And we were able, from this point of procurement, to have it under NHIF, not SHA. So SHA had to comply. So fully paid. The cost of that one scan is 40,000. Is what SHA is paying. So my thoughts and opinion is, because that is now based on the cancer treatment and we have protocols, so easily managed, no patient goes before they are booked. And you only need to send your documents, the clinician sends the documents of the patient, they are reviewed, they discuss with the team, and then the patient is admitted. So in the same context, you can also, as psychiatrists, do some guidelines to be able to use that PET scan for the most relevant cancer. But otherwise, we all know everybody can use it as a very expensive treatment.
Clap for her, ladies and gentlemen. So that is evidence-based. Yes, so we are doing something. There is something that is there. We just need to have more gatherings like this so that you can share this information, because otherwise we'd have gone home thinking that we're hopeless and helpless in the eyes of the government. So, so we are doing something. So back to the reason why I'm here. I will stand on already established protocols. That is something we do as government. Again, boring you here. I don't want to bore you because I know you have a lot of knowledge that you've acquired today and you want to go and utilize it and also to share a cup of tea. I just want to take this opportunity to really thank Chiromo Hospital Group, Dr. Frank Jenga, and Dr. Neil and the organizing committee, the sponsors who are out there who have supported this whole symposium. It's really incredible what you're doing for our profession. I don't think we've had this happening in the last couple of years. And when you started this last year, away from what we do in KPA as the usual CMEs and national conference, this is a more close-knit family of mental health profession talking about what we do every day. So thank you very much for organizing this second symposium. And I do appreciate also the speakers who have been able to share with us the work they're doing, the work that is challenging the narrative that we're doing. When I was sitting there and Dr. Simon was talking about dementia, and then there was Dr. Katwa talking about the future, and that now we may need to put away ECT. I was like, I just launched the National Clinical Guidelines 2 years ago now. This dude want me to go and start reviewing them. No, you know, I know in my head I'm thinking, yeah, it's good progress, but now we also need to keep updating the policy documents that we have in place. And we accept that challenge because we are here as policymakers to guide and ensure that we give the best evidence-based interventions for our Kenyans. So today's discussions are really very futuristic, and they remind us that mental health care will increasingly be shaped by innovation, technology, and evidence-based practices. So we must carry this information to our daily practice, not just leave it here in this room. From the Ministry of Health, because I'm speaking, I know I wear many hats and people are wondering which hat am I speaking. I was invited as Director of Mental Health, so I'm speaking as a policy maker. So from where I sit in the Ministry of Health, we do take such information seriously so that we can guide the policies and the investment that the government makes. Because I know when government makes policies and gives direction for investment, stakeholders also take the same direction and invest in the same. So from the perspective of the Ministry of Health, innovation must always be accompanied by equity and accessibility. And as we adapt new technologies and approaches, we must ensure that they translate into better mental health services for people across all our counties and across all divide. It must translate into better access to quality mental health for every Kenyan. There has been a lot of talk on SHA, and I know we have said that the current benefit package for mental health is not adequate. Yes, it is not adequate, but at least for once we have a benefit package that is just for SHA. I was speaking over lunch with my senior colleagues here. And speaking of senior colleagues, I've just realized I also entered that bracket of senior colleagues, Dr. Ochieng, yeah, you know, yeah, as senior colleagues, you are conversing earlier over lunch and saying that we do need to give our inputs to the SHA package. And I know that SHA is revising those packages. We have a benefits tariff advisory team. It's called BTAP. They advise the management at SHA, they advise the Ministry of Health on how we need to improve the package based on the experience. That team reached out to us and told us, we have a window this month to submit a memoranda to them for consideration of what changes we want to see made on SHA. So we're going to be, as KPA now, oh gosh, confusing now. Let me switch gear. Now, as Kenya Psychiatric Association, we are planning to put together a small team of professional association, private hospital, faith-based association, and even public facilities to just put together a memoranda to submit to SHA on what we want to see the mental health package looking like. So when we call upon you, especially you young people in the house, please come forward and participate in this exercise so that whatever package that you envision to see for mental health is included. Is that okay, guys? Will we work together on that? Yes, so I just wanted to mention that Kenya and the Ministry of Health is ready to adopt new technologies. I think you've all seen, just, is it last week or the week before, Kenya got the first batch of long-acting injectable HIV medication. You saw the minister receiving that. Can you pronounce that name? Yes, lenacapavir. So that we are willing to adapt to what is evidence-informed. That was just an example I wanted to give. So I just want to also echo the emphasis that was given to youth mental health. Dr. Katara, wow, yes, we have a challenge. We don't have youth mental health programs. What we are doing is working towards integration because we do not have enough specialists. We cannot split you, Judy and Dr. Omondi, to cover the entire country, but we do what we can with the resources we have through integration. And I commend Aga Khan University for the work you're doing in terms of creating the capacity of our healthcare workers, multidisciplinary team to be able to support even more growth in that field. But we want to also emphasize that the youth are the future of this country. And the same way, the youthful psychiatrists and psychologists we have here are the future of mental health practice in Kenya. So I want to commend Dr. Neil Horn and your team for being heavily inclusive of the youth, the registrars in this process and in this symposium specifically, because we've actually been listening mostly to the registrars. That is very commendable. You're the guys who are going to take over from us in mental health, and you're the ones who are going to develop the next set of policies. Us, I think our role will end in 2030 because we envisioned until Vision 2030. Yes, yeah. So as I come to a conclusion, the ideas shared here today should not remain within this symposium. We should take the challenge and move them to practice in our spaces. And I want to encourage the youth again, don't be too comfortable just in one line. I know the style of mentorship you're getting from Dr. Frank here cuts across policy, management, clinical practice, research, and all that. But most of you are just choosing to open clinics and stay in a comfort zone of just seeing patients and going home in the evening. Who will be left to them make the policies? It is us with gray hairs. And we'll continue saying, write your prescription on a piece of paper, yeah? While you would want to see everything digitized. So I'm challenging you that, can you also move into the policy spaces? Can you move more into research? Can you move more into training, not just sticking to the clinical practices? So the future of mental health in Kenya will be shaped not only by policy, but the collective commitment of clinicians, researchers, institutions, and partners such as those who are presented here today. And I also want to thank our neighbors from Uganda, Ethiopia, Tanzania for being here. I know we are learning from each other. Is what we have to learn from you. I know you learn a lot from Kenya because you have quite a number of policies and a lot of advanced interventions here, but we also learn a lot from your practices. And again, thank you for including the region. So let us all take it as a collective responsibility to translate what we've learned here into real work in the spaces that we influence. Thank you very much and have a good evening.
Thank you, Madam President. Thank you, everyone. We are coming towards the end. I'd like to thank all distinguished guests who are able to grace this occasion and able to also stay and be able to participate and listen in. I would like to appreciate all speakers that were involved either virtually or physically here. I would like to also appreciate all attendees, both virtually and physically. And I'd like to challenge us as well that maybe next year, as attendees and listeners, maybe it would be our chance and opportunity to come to this side of the podium. So feel free to reach out to any of the committee members of the organizing committee if you are interested in being a speaker or presenting something on the next, hopefully next year's symposium. I'd also like to thank our sponsors, who are Johnson & Johnson, the Ministry of Health, Cosmos, Novacy, Square Pharmaceuticals PLC, Synamed, MSN, MeLife, and Sun Pharma. And feel free to visit their booths out there as we have our tea. I'm told one of the sponsors, Square Pharmaceuticals, has a cake, and I will randomly appoint Dr. Sylvia to cut the cake. So feel free to join them at the cake cutting. Oh yes, we forgot to take a photo of the afternoon's speakers. I think afternoon speakers, you can just come up front. Maybe we can give them a round of applause. Yeah, and the moderator as well. Yeah. Thank you very much. Finally, the weather has given me the opportunity to make a joke, but I wouldn't. And I will end it by probably dropping the mic, but thank you very much for having us. My name is Nyamiobo Joseph. I've been the master of ceremony of the day. Thank you. Oops, I forgot. There's tea. So feel free to enjoy tea at the back.